Dr. William O'Neill. I'm the medical director of the Center for Structural Heart Disease at Henry Ford Hospital in Detroit, Michigan, and I'm an interventional cardiologist. It's still problematic because there's still a state of uncertainty in terms of what CMS is going to do in terms of something called a RAC audit. There haven't been any major programs that have had these kinds of audits where CMS actually comes in and see whether or not the patients were appropriately billed. And I think until we have a few of those available, there's some uncertainty. The programs are certainly trying to be very meticulous to follow the rules. Two surgeons have to see the patient to deem them either high risk or inoperable. There's a lot of other rules that are going to be required. So I think that is kind of tampering the enthusiasm for using these valves. As far as the profitability, there has been some increase in the reimbursement for institutions. Still, about half of the patients, it's problematic. They're either neutral or lose money when they get treated with these products. St. Jude's valve, I think, is really important to talk about because they basically stopped selling their valve in Europe and stopped all U.S. trials. This is based on analysis that Dr. Carlos Ruiz from Lenox Hill did on some of the patients that they had treated. What he did is a 4D CT, so basically it's a moving picture of the CT scans, which are very high resolution. And in that, he noticed that in two patients, one of the valves was not working. It basically had been stuck closed. Now, the patients were asymptomatic. There was no gradient. And it really has raised a great deal of consternation. So, you know, I think it's way too early to make anything about this. The company was probably overly cautious in stopping the trials. There hasn't been any proof that there's been any delayed late failures. And the durability data from Edwards at 5 years and from Medtronic at 2 years really shows that the patients are doing very well. So my suspicion is going to be that these were very chance occurrences. The other thing that can happen early on is in a very small minority of patients, clots can form on the valve leaflets. It's known to happen in the surgical valves, and probably some of these patients develop some clots which decrease mobility. So I think it's just really important that these patients have to be followed on a regular basis. We do an echo at 1 month, at 6 months, at 1 year, and then yearly thereafter. And that still is a very, very good screening tool for durability. Yes, just last week, the TCT meeting was held in Washington, D.C. This is an international meeting of physicians practicing in cardiology, interventional cardiology, and structural heart disease. It's a demonstration course and a venue for presenting new late-breaking trials. Trial data first. At TCT this year, 5-year results from the partner SAPIEN study were presented, and 2-year results from the original randomized core valve versus surgery trial were presented. Nothing really new and earth-shattering. It basically just shows that both valves were very durable. The results originally from core valve have been maintained over 2 years. And interestingly, the data from 5 years shows a continued durability of the Edwards valve. So the good news is that there weren't any unpleasant surprises and no late valve failures or structural failures that really could be found. Paravalvular leak is probably the thing that's the most important because it has long-term survival problems. The Edwards valve, the original Edwards valve, is shown to have paravalvular leak up to 30% of cases. And in those patients, the 2-year survival is substantially reduced. So I think that's really probably the #1 safety issue. The other issue that is in particular concern is the core valve risk for pacemaker, and anywhere between 10 and 30% of people that have core valves implanted have pacemakers that are going to be required. There hasn't been any data showing that pacemakers are an adverse consequence, but they are definitely a nuisance and increase the cost of hospitalization for the patients treated with a core valve. Data, I think, is reasonable. Originally, the very first partner experience showed a bothersome incidence of stroke. I think a lot of that was related to the patient population. These were like the most extreme risk group of patients that hadn't ever been treated before, and anywhere from a 2 to 5% rate of stroke. As the population becomes less risky, the stroke rate is dropping. One trial that was presented at TCT was the study with distal protection, being carotid protection for strokes. And that does look like it's going to be a very interesting therapy. So I think we have to keep an eye on that, because it looks as though we can put filters in the carotids and minimize the chance of embolization into the cerebrum during TAVR implant. First study that's actually been presented, there was a 100-patient randomized trial. Half of the patients were control, half of them had the carotid protection. The endpoint was embolization manifest by a diffusion-weighted MRI. These are small little sort of micro strokes that are present. Major strokes are pretty infrequent. It would be nearly impossible to do a randomized trial to decrease the incidence of major strokes. But there is concern, obviously, that you're embolizing particles into the brain. No one knows yet whether or not that's going to have problems in terms of cognitive dysfunction, but at least we know that we can definitely decrease distal embolization with these carotid filters. The annulus dimension is at the outflow tract of the left ventricle, just under the aortic valve. Those dimensions can be anywhere from 16 to 30 millimeters in diameter. So, and it really depends on the body size and the size of the heart. Very variable from patient to patient. Older women tend to have smaller annulus. Men tend to have larger annulus. The problem is that you have to size the annulus properly. Early in the Edwards experience, we were probably undersizing valves. We were using half of the patients were treated with 23 and half with 26. Now we only treat about 20% of the patients with 23 valves and up to 30% of the patients with a 29 millimeter sapien valve. So I think that one of the problems that Edwards had with paravalvular leak was simply that we were undersizing the valves. We understand better now with CT annulus measurements how to size these properly, and we're tending to use larger and larger sizes. Originally, the core valve had a advantage because they had a larger annulus size valve. Edwards did not. Edwards now has a 29 millimeter valve that it seems to be comparable in terms of the annulus sizing. So the original advantage the core valve had in terms of being able to be offered in larger valve sizes, I think is it has been neutralized with the new 29 millimeter sapien XT valve. When the TAVR valves first came out, they were brand new valves. No one knew how to use them. No one knew what the durability was. And so it would have been really inappropriate to take patients that are good risk for traditional surgical valve replacement and use an experimental product. Now that there's been more than 10 years of experience with these TAVR valves, I think we're starting to appreciate what the complications are and what the durability is. And the valves actually appear to be very durable. So as that happens, people are using it in lower and lower risk patients. In Europe, if you're over 75, hardly anyone gets a surgical valve now. The vast majority of people in Europe over that age group are being treated with TAVR valves. That hasn't happened in the United States primarily because of CMS regulations. When the TAVR valves were first approved in the U.S., they were approved for a high-risk inoperable group. We couldn't use it for medium-risk patients or for low-risk patients. Now, risk is defined by the heart surgeons. There's a heart team. The heart surgeons evaluate the patients. We use something called an STS risk as an initial calculator, and then the surgeons have to take a look at the individual patients, and they have to estimate whether or not the mortality is high, low, or intermediate. For low-risk patients, so if you have a patient that's 75, no other comorbidities, is a man, those people have risks of less than 2% of surgical valve replacement. And in those patients, we're still not treating them with TAVR valves. It still is for medium-risk patients, which are STS between 4 and 8, or other comorbidities, or people at very high risk or inoperable. There's a large population of patients in the United States that are still getting surgical valves, and it's primarily because they're at low or intermediate risk.